Welcome to another show with Kevin and Jaron. And today we have a guest with us, Maka. And we are excited to have a friendly chat with her about the profession and the directions we want to go. Kevin, what do you got to say?
Yeah, I feel like when it comes to new frontiers, it's always nice, Jaron, and I might be biased, just like a tiny little bit, that it's always nice to have new frontiers focusing on WSU Cougars. You know, just bringing some old colleagues back and getting to see all the cool things they've done in their career. We're talking a little bit before the show about how our careers have kind of gone non-traditional in lots of ways and perspectives we gained from that. And so I'm really excited to hear some of Maka's stories and lessons from trials over time on how we can help the consulting pharmacy world realize some potential and some opportunities that are out there for sure. But I think to start it, really, Maka, please give us an intro to yourself.
Yeah, hi. Thanks, Jaron and Kevin. Thanks for having me. I really appreciate the opportunity to be here today. My name is Maka Riley, and I am a licensed pharmacist here in Washington, although it's been some time since I've actually dispensed prescriptions. As Kevin alluded to, have worked a very non-traditional pathway through my career and have been lucky, really, in a lot of ways to land some of the roles that I've had because of opportunities that I had from previous roles. So I left pharmacy school at WSU and went the community pharmacy route, expecting to work my way up through district management, regional management, and went to Target really early. And then after that, I spent some time at CVS and then made the jump over to Kaiser. And at Kaiser was when I was really exposed to the mail order pharmacy world. And it was a world that I didn't know existed before or even had a thought that I would have an opportunity to do because I had all of my experience in retail. And I was like, you're really going to trust me with all this multi-million-dollar equipment? What I can tell you is I can lead a team. I can help drive, efficiency and try to solve problems. And I realized that's really what the mail order world was trying to do, was fix access problems and convenience problems. And I learned a great deal at my time at Kaiser. And then after I spent about 5 years at Kaiser, I joined Amazon. And so that was a very pivotal time when the PillPack and Amazon acquisition was happening. And it was a very interesting time to be there because Amazon wasn't necessarily welcomed in the pharmacy world. And I'm not sure that they actually still are, but it was very interesting being on the inside and learning about what their mission, vision, and really trying to bring ease and convenience to their consumers. And I think that's really at the bottom line what we are trying to figure out in pharmacy as a whole is how do we reach all the people across the nation, and how do we fix the access to care problems? And I spent a lot of time at Amazon reflecting on that, and I learned a lot about how it really can be done with really good access and connections, and really owning, what Amazon does really well is they own the transportation space, they own the fulfillment space. But the one thing that I felt like I was missing at Amazon was really focusing on the equity piece. And about a year ago, I decided to leave the pharmacy industry as a whole and join the Washington State Department of Health. And now I work with a team that really focuses on bringing access to healthcare, and particularly in rural parts of Washington. But I think the lessons that we can learn from that is really applicable for all of the nation. And it's a really critical time, especially with where we are politically, to ensure that pharmacists are on the forefront of helping to solve that problem. So that's a little bit about me.
Oh, super helpful, Maka.
Yeah, go ahead.
No, I'll let you jump right in, Jaron. Go ahead.
So, I want to dive into the jump from, Amazon to Department of Health. That's a pretty big jump. But before I do that, I think might have a unique perspective on
Jaron's
kind
jump
of
just
what
froze him on
happened
screen
in,
right
in
there.
two
I'll
scenarios
take
that
my
were
question
probably
in
very
there,
similar
Maka, in
for
between.
you.
So when Jaron's coming back online, I think the one thing that I wanted to make sure that we kind of covered is your road is winding, extremely so, right? I mean, I think there's a few threads that you can pull through there, good at leading teams, good at kind of scaling operations overall, good at identifying some opportunities within systems. But there's a number of elements that are non-congruent, right, within the Maka journey of a career. Tell me this, when you're going from one thing to the next, what'd you learn and what'd you lose when it came to the transitions of each of those jobs?
That's a really good question. For myself, I think as I progressed in my career, I learned confidence in just like the skills that I have learned from each organization and have felt empowered to want to help and bring up the next generation of pharmacists and not just pharmacists, healthcare providers as a whole. I think that's really important for people to understand the impact that you can make. And it's not, especially when you're working in places like mail order or state government, you don't always get to see the individual impact that is happening that you would see in a community pharmacy or an independent pharmacy. But every single one of us in the health system makes a difference. So I would say for myself that personally, I just learned trust in myself and my skills and being comfortable enough to talk about that and challenge the people around me to think differently based off of our experiences. The other thing that I learned is it takes collaboration. And I think that every single one of us brings like a piece to the puzzle. And without each of us, the puzzle's incomplete. And I don't think that there is a single pharmacist that can fix all of the problems out there. So it really is dependent on who you know, like what is the problem you're trying to solve, and can you get all of those people in the room quickly to get whatever problem you want solved, and not being afraid to step up and be that leader that challenges people to be a part of that solution. I mean, we've seen a lot of really innovative things happen during the pandemic. And a lot of this stuff wasn't new. It's just we haven't had to take it to the scale that we did during the pandemic. And it was all based off of like connecting people with what programs already existed, with people that had resources and people that were willing to do. And then I think, Kevin, your other question about what's something I lost.
Yeah.
That's a really good question. And I remember when I worked in the corporate world, particularly Target and CVS, like I always questioned, like, why were the procedures so rigid? Like, why did they like tell us everything that we needed to do by the book? And if I had the autonomy to do X, Y, and Z differently, something would probably happen. Yeah. And when I jumped over to the startup world, and even here in the state government, like it is helpful to have definitely clear expectations. I think it takes away some of the risk that comes with the job. But I think there also is, you have to have the ability to know when to take risks outside of those boundaries as well, because that's where the innovation comes in. So I think I would say what I've lost over the time was like being more bound to structure and being more risk adverse. So I think I take it as a positive, not so much as a negative.
It was something you were willing to give up.
Yes.
All right. Well, that was actually kind of what I was going to ask, because it seems like you've had two very similar situations where you went from Target to CVS during that acquisition, and then you also went from PillPack to Amazon during that acquisition. So I bet you witnessed, like you said, startup versus massive corporation protocols, undermining of our expertise, basically to fit within a perfectly square peg or whatever.
Yeah.
So,
and it really was that. I mean, a lot of what we had to do when we became Amazon is scale really, really quickly. And what you don't want to do is reinvent the wheel. So there were enough of us that had experience from working from other companies that said, we really like this. We know that, this company had really good compliance in this area or really well written policies in that area, and going and leveraging what we can find. And there's actually a lot of resources that exist in our own associations and our boards of pharmacies, that if you are willing to do some of the research, that you don't have to actually take on doing these things that should just be infrastructure for a pharmacy, and spend that energy in other areas.
Right. So you've been at the Department of Health now for a year now, right?
Yes.
Okay. So I was looking at some of the things that you've been working on. I saw the rural nursing deal that was put in place. I thought that was really cool. So tell me, what unique things have you seen from pharmacists in your first year that you would like to see more of?
Yeah, I think that's actually a really good question. And one of the things that I actually was surprised at was I sat in a lot of meetings that had to do with how we fix access to health problems. And it was often providers in rural areas, specialists. How do we get people to get connected to specialists? How do we provide or create a pipeline of nurses that are going to stay in a rural area? And these are all very important and great questions. But what surprised me was there was never a conversation about pharmacists in that equation. And
yes,
I know that there are very strong relationships between the Board of Pharmacy, the Department of Health, and the Pharmacy Commission here in the state. The Pharmacy Association and the pharmacy schools. But I think that still highlights that area where pharmacists are often overlooked in the bigger solution to fixing this problem. And often pharmacies are the only access point in many communities. So really thinking about, how do we get that exposure? How do we get the resources? And how do we not overload these independent pharmacies that are such critical components in these rural areas and still provide the access that's needed? And the rural nursing education program is something that we're looking at. It's a very innovative idea where we're looking at getting nurses who live in the community that are interested in growing their career and will stay in the community after graduation. We had very similar programs to that as pharmacists, at least when I was in school, but not necessarily tied to rural areas, but to like specific patient populations. And I know that the Washington State Pharmacy School also has a rural pathway as well. But it takes these like ideas of, or actually identifying these problems and coming up with ideas to solve the problems, but they're still very small, right? Like the number of people in these programs are so low. They're not enough to fix the entire problem. I think I calculated it would take us like 20 or 30 years to get like 8 to 10 nurses through to fix the nursing shortage in the state. It's not enough. And I think that's where I have this dilemma that I challenge myself is, if I had the money that some of these large corporations have that could put more people through these programs, could we fix this shortage sooner? And I ask myself, like, whose responsibility is that to solve that problem? And
That's a really good question. I mean, I think the responsibility when it comes to different payment models and incentive systems and looking at the way that we've kind of set up our healthcare ecosystems is not just a good question. I think it is the question, right, in general, of who's going to be responsible for it because we've incentivized them appropriately. One thing we've done and we failed over and over again is large corporations and state governments have failed to incentivize the right players that are available inside of systems. Pharmacy is a really good example. We've got pharmacists that are available, but when programs come out there and dollars and cents go toward efforts, what ended up happening during COVID? We didn't look at community pharmacies. We went directly to CVS and they failed. They dropped the ball. And then community pharmacies grabbed it, were able to do something with it. The same thing with long-term care, independent pharmacies. Once again, those folks were overlooked initially and now they're being looked at. So me saying this, and thankfully, you and I having background being friends, I can tell you this, the jobs you've had, Maka, like over the years, like those are the jobs, like those particular employers, which I just love about your personality is that those are all the ones that the world of pharmacy throws darts at. Like you've worked at CVS, you've worked at mail order systems, you've worked with Amazon, and now you work with the state. Like all of those pieces are usually like, here's all, you have all the employers.
And I'm still smiling.
You're smiling and you're still advocating for pharmacy, to be able to do more things, new things. And it really speaks to being able to innovate from within, those individual systems. But maybe give us a spin, a little bit, Maka, on working within those entities and seeing, here's the outside perspective of why those entities are bad for healthcare, bad for pharmacy, all these things kind of coming forward. What are the positive things that you could see some of those entities doing if they changed their incentive-based system, or if they changed a few things that would be more fitting for our healthcare community, especially pharmacy community, to be able to participate?
Yeah, that's a good question. No, I think every single one of those companies bring some positivity, especially when I think about CVS has done for the regulatory landscape. Yes, they still can and should do more, but the presence that they have shows the power that they have, and like that didn't come overnight. So that's a lesson to be learned from the rest of us in the industry. And I think about, I'm going to answer your question about Amazon slightly different. And I would say, the one thing I learned about Amazon, right, when I joined it was everyone was very worried about Amazon taking over the pharmacy industry or just the healthcare industry in itself. Right. And the one interesting thing that I learned was never once when I was in Amazon was that even brought up. That was never, it was never about taking over as much as it was challenging and disrupting the roadblocks that exist in healthcare. Mm-hmm. And to be able to have the money back, behind a corporation like that allows you to make mistakes. It allows you to challenge and think differently and do programs and do pilots of things. And then if it fails, pivot really quickly and not disrupt your entire business line. That can only be done when you have that much amount of revenue to back you up.
Yep.
Right. So I do applaud a lot of the initiatives that Amazon has done with creating direct-to-consumer initiatives. I do think that model is a really well thought-out model. The problem is it works really well for people who already have access to care, people that already have money. It doesn't solve the inequity problems. It doesn't, even if they solved the access to rural health areas, would they be willing to help the people in the rural health communities that actually need the help that don't have access? So I think those are the things that I think Amazon has done really well. The Department of Health, I think, they're trying to do all that they can to regulate and ensure safe access, because there's still bad actors in the community. And it takes one or two really bad apples to sour the rest of it and make it much more difficult for us. But where I think all of these companies, including Department of Health, and I need to say that this is my own opinion, not my employer. I'm not speaking on behalf of the Department of Health. This is my own opinion, is that we need to work together to figure out where regulations don't make sense anymore. Where are we becoming the roadblock? And
Yeah.
how do we get past all of those items so that we can solve the bigger root of the problem, which is not just bringing healthcare to people, bringing like whole person care. That includes like the social aspects, transportation, food, nutrition, education, all of those things. You can't just solve the health problem without solving all of those other issues. It's just such a complex problem when you take it from that spin and that perspective. And I think that's what has continued to fuel me in my career is like, I feel like I fix or I get a little piece of the puzzle, like a little better and then a little better and a little better. But when one day when I look back on my career, I want to be able to proudly say like I made a significant difference for a huge population of people. And then I will know that my work has been done in the industry.
It's a wonderful
Absolutely.
aspiration for sure. I hope that's exactly what happens.
You know, that's a perfect segue into something I wanted to ask you. So, what are some regulations that you personally are kind of have on your target, like your eyes set on? Like, what regulations do you feel are the biggest obstacles that we need to target, and what are some of the things you want to do to overcome and pass those barriers?
Yeah, that that is a loaded question.
Yes, this is.
I mean, Kevin has said it several times. It's about reimbursement and ensuring people are compensated fairly.
It's
We
always
cannot
what it comes down
we,
to.
we can't expect people to keep working for free. And we know that there are a lot of really generous people because there were a lot of people out there in the pandemic risking their lives administering COVID tests, vaccines, all of those things, and volunteer time. But that's not sustainable. That's not a long-term scale solution. So all of the reimbursement regulations and I think Medicare and Medicaid, we really need to look at that. What a critical time for us to be looking at all of those regulations and opportunities. I'm going to bring up one that I think is really worth mentioning because it was such a big component of the we call it the OBBB, the One Big Beautiful Bill, but we'll just use the acronyms, is the Rural Health Transformation Bill.
Yeah.
And the access that potentially money could come from this. At DOH right now, we're taking a survey from stakeholders that we are wanting to hear how people would like us to spend that money if we get it. And we're working alongside Healthcare Authority, who will be the lead on our application for the state. But this is an opportunity for people to share insight. But I really challenge, like, this is going to be money that's available to every single state, but you must apply for it. And the federal government is going to make it really difficult for us to apply because the terms are going to be really short. So we really need to be having these conversations now, discussing what can be done in the short term. It's a 5-year program, so not everything needs to be done right away, but they're looking to push some of this money out right away. And so I think this is opportunities for things like rural nursing education programs, rural pharmacy programs, access to care, getting, credentialing provider status in rural areas. This is the opportunity to push all of those things through regulation right now because the money will be there and it will be backing it. And if we only have 5 years to get this done, we know how fast the COVID dollars disappeared. We got to be all over this.
Yeah, yeah. And just getting a couple of things about that. First of all, we need payment structures, but we need them like not associated with a product. I feel like not only does this happen in practice where we have an opportunity to perform a task or a service and charge for it, but then we center it around a product and getting a product out. And I feel like that shortchanges it. And in my experience, and this goes several experiences, I've always noticed that a clinical service is going to be shortchanged when it's only centered around that product. And we're just shortchanging ourselves. We're limiting ourselves when we only allow our services to be tied to that. So not only do we have that problem within our own ranks, and that's just my opinion. I'm sure people will disagree with me. Um, but also knowing how to bill for your time is such a huge obstacle for us.
Mm-hmm.
Even if we get the ability to bill for our time, so many pharmacists have no idea what goes into that task, the documentation, the credentialing, everything. And so, like, just those two aspects alone are a massive overhaul to our industry that need to take place for us to really take the next step, the next level, to the next frontier, so to speak. So, do you think, is there anything that the Department of Health is, like, any objectives or initiatives they have to uh, maybe change the education of pharmacy schools that they're providing?
Yeah, I think the one other thing that you missed in that is the administrative burden in itself, because
Yeah,
you're not getting paid for that time that you are completing those administrative tasks, and they're very, very burdensome.
yeah,
Um, I would say that, a lot of our programs do provide technical assistance, and they're tied specifically to the programs that we support. Like, specifically, my area has very strong relationships with the hospitals. Um, our partnerships with, I think, the schools continue to be something that we will develop over time. I'm, especially here in Washington, I'm really in tune with Jenny at WSPA and Julie and WSU. So I have actually been on the backside of things like, hey, my programs, please call these people directly, see what we can do. And it did take somebody being inside to build those relationships and really challenge, because I think the other thing is that we have connections. The DOH has always worked really well with both pharmacy schools and the Pharmacy Association. I mean, they are on meetings on a regular basis, but I think it's really like pushing the line and saying, okay, well, pharmacists could do this instead of this contract, or, where do we, what is allowable, and how do we scale people up to work to their highest level of their credentialing? So the other thing, though, and I think it's actually more, it's less so of a teaching people how to bill as much as it is like, how do we just make this like an automated process? Like, and this is where these large
yeah,
corporations and these startup companies come into play, because these companies, they don't focus on writing policies and procedures. They're looking at their tech code and figuring out APIs that can just do this stuff manually based off of an input. And that's really the level we need to get to. And where the state and states in itself can provide is like offering these solutions to independent pharmacies and smaller organizations that don't have the capital that these larger corporations do. But that's where the money in these corporations to fund innovative ideas is really, it can help us, can help our profession. And
yeah.
that's where I'm saying that every single one of us plays a piece in this puzzle.
Yeah, I think that brings up something fantastic, Maka, between scale and you were saying technological kind of integration. So, working across states and seeing behind the curtain of systems that have been developed by individual states, I'll give them a pass that they're not tech experts, right? And when they're
Mm-hmm.
developing systems, they end up becoming extremely painful and burdensome for people to enter information inside of. And at the exact same time, the scale, the monetary scale of having more people enter more billable hours into those systems could be crippling right? I mean, there could be a reason why you're trying to throw roadblocks up, is because if you have too many people go through the system, it could be very problematic from a budgetary standpoint.
That's fair. Yeah.
Give me this on the innovation side, Maka. If we're going to look to automate more, right? If we're going to look to automate processes, get clinicians, if they're pharmacists or nurses or an entire collaborative team, which would be my preference, and they're under a value-based care contracting system, and we have these automated pieces in play. We have more people seeing individual providers. They're seeing them for more periods of time, and they're billing for more. Unfortunately, we have a significant deficit in our state, and across the U.S. Healthcare is struggling mightily. So what do you see when it comes to using non-human being efforts to be able to scale them up? In other words, I would love to have Jaron see every single one of my patients, right? I'd love for him to see all of them. That would be a huge waste of Jaron's time and a waste of my money. But if I could choose the patients that Jaron is seeing based on where he's going to have the most impact, the most ROI, like I'm seeing a very significant win, right? Of being able to kind of cherry pick the system. But everybody else still needs to be seen, and they need to be kept out of, the next hospitalization. What are you seeing, Maka, when it comes to states kind of realizing that and going, well, here's how we stratify, our populations to be able to help the gerunds, the pharmacists, to be able to take care of these populations they can be most effective in, and utilize tools like LLMs and AI, et cetera, and have some expansive regulatory burden removed so those systems can work for patients as well.
Yeah, I mean, there's several complications with that, right? First and foremost, that's like the community having to trust the state to lead a process like that. Like trust in itself in government is really difficult no matter where you're at. Mm-hmm. And I think that also brings into the bigger question, what is government's responsibility in this? Is it to solve the problem, or is it to convene and bring people together to collaboratively solve the problem? Right? And so I don't know that the state will ever be able to single-handedly solve this. This has to be a collaborative effort. In terms of being able to, produce smart technology, like I believe in our lifetime it will happen. I think we are seeing really incredible strides in being able to provide knowledge that we didn't have access to previously, or decrease the amount of time it takes us to solve problems because of things like artificial intelligence and LLMs. But I think I also don't believe that it will ever replace that one-to-one relationship that people need to have in their healthcare experience either. Mm-hmm. Like I will tell you that, in all of my career, I still go and pick up my prescriptions from Safeway Pharmacy because I have a really good relationship with the pharmacist over there. So I give up my convenience and my ease of having it delivered to my door because I look forward to that once a month visit to going to see my pharmacist. So I believe that it will make us more efficient. It will help break down some of the barriers that we can't do with people, but it's not going to replace the need and desire to provide human-centered care.
Mm-hmm. Could not agree more. Yeah. That's just an aspect that you cannot totally replace, and I think that says a lot about us as a species. That really is an integral part of our species. Just that interaction that we have with individuals and that human touch. Mm-hmm. But I heard somebody say that the revolution, I forgot what it's called, the revolution where we started to make machinery, and that was the revolution that helped us overcome our weaknesses of our strength, right? So our muscles. So we were using machines to lift stuff. And this next revolution is help us overcome the slowness of our minds to what computers are. And so it's like it's going to accelerate our evolution of, so to speak, of what we're capable of doing. So,
Yeah.
um,
I think the other possibility, though, is it also could provide us the data to say, why are we doing X, Y, and Z administrative burden that isn't producing anything? Like, it's not fixing patient safety, it's just adding cost to healthcare. Those are things that we haven't been able to quantify up until now. So I think having that data could potentially lead our profession to being more successful in changing regulations in the long term.
yeah, absolutely. So, um, I love that you work at the Department of Health, because I think I want, and we were chatting briefly before we started this evening, but one of the things that I find interesting is that people who are passionate about pharmacy and want to get at the roots of what helped them become a pharmacist, it's ironic that the things that help them fulfill their passions is when they end up, well, unfortunately, leaving a pharmacy. So, I think a crucial part of our survival, our evolution as a profession, is to diversify. And
Mm-hmm.
so, one of the goals of my career and the company that I own and I run is to infiltrate as many levels of healthcare as I possibly can. Um, and so we're in M care, but we're not enough. We're in primary care, but not enough. Uh, we've been doing consulting pharmacy for 30 years, but not nearly to the level that we're capable of doing. We want to be providers, but that's a long shot, and we have so many other opportunities at our disposal. So, you're in the Department of Health. We've infiltrated managed care very well, but I think one of the things we need to prove is that we're better than just drug cost reducers. Uh, we can manage disease states. We can be
Yep.
a supportive aspect of the healthcare team. And like you said, we are constantly being overlooked. And like I said earlier, I think that's one of the reasons is because we're still thought of as product pushers rather than clinicians. And
Yeah.
so the more we start to infiltrate different aspects of healthcare, the more likely we are to meet that and find that new frontier that we have yet to get to. So,
And I
any,
don't think that that's too far off. I mean,
yeah,
I think that, you know, we're going to be the frontline people for behavioral health issues, for opioid overdoses. Like
very good
we
point.
have been for a long time, contraception, right? We're
Yeah,
making our way into the realm of end to end chronic disease management. I think that another big piece of that is we need to be vocal, loud, and give recognition and praise when our community does it really well. Because we as pharmacists often like to hide in the shadows and we're very humble people. We don't like to put the
the
spotlight on
humblest.
us, and we
Other than
need
Jared.
to.
Other than
We need to start doing that more. We need to start lifting each other up.
Amen. I can't agree with that. And the one thing you tied together there, Maka, is you said we have the data now. And I think that's a really essential element that one of our colleagues, Donna Bartlett, is always huge about, is saying, is there a way for us to at least track the ICD codes, the CPT codes that are related to the interventions that we are making, even if they're unbillable, for us to be able to pull some of that data? Granted, Donna is in an academic, institution and setting. And so that allows for that data procurement, grant-based funding, that space. But I do think now with the accessibility to data within some of the infrastructures that we're working in with electronic health records, we have that capability if we can stamp it with, this is what Maka did, this is what Jaron did, inside of the system. And then we can attribute that to what happened to an individual over a course of time after they were seen by a pharmacist for intervention. My question is this, I guess, Maka, to you on that data element. How are we going to pull that together? Like we have all these great ideas, right? We have all this data. We have these human touch elements we want to put in place. We've got, as Jaron is mentioning, there's a there's a ton of opportunity for pharmacy to be successful. And as you said, it's really close. How do we get over that line? Like, where do you think the next best steps are for our profession to do so? You said be vocal, which I love, but be vocal about what, and how do we make those things to be vocal about?
Yeah. Oh, of course you had to save like the hardest question for. I mean, that in itself lies like the deep question is who's willing to give up the data? It's not measuring the data that's going to be difficult.
Well said.
Is it, the right answer is a collaborative approach, because I think it's going to take many stakeholders at the table. But we as a profession, as healthcare providers, need to agree that that's what we want to solve. Like, that's the problem we want to solve. Because I do think that I can guarantee that there are probably some companies out there that are already measuring some of this data, but they don't want to share it.
There are.
Yeah.
Just kind of trying to wrap things up. So just out of curiosity, what do you find inspiration in more, like in music or in like movies or like TV shows? Like, what do you like? Do you like music more or like multimedia more?
Yeah, definitely a music person. I grew
Okay.
up in Hawaii, so like,
Okay.
island reggae music is definitely my calming place.
All right. So like what music right now is giving you the inspiration or the umph that you need to really push us forward? Like, what are you
Yeah.
finding inspiration in right now?
There's actually a local artist named Kalohe Kai who wrote an entire album called What Aloha Means. And that's purely that. It's, growing up on an island, I didn't see people by color, by like amount of money people had. We like operated in a sense that everyone was equal no matter what. Everyone was your brother, your cousin, your auntie, your uncle. And you treated every single person with respect. And the other thing that I really have tied to in this album is he actually wrote this at a time when he was facing depression. And he had an injury. I can't remember what it was, but he wasn't able to sing, and he found his healing in surfing. And his mom had a really long talk with him that like he is such an influential person in the Hawaiian community that has a voice with his music and that he needed to use it. And I have to remind myself every single day that how I got here to be a pharmacist, I'm very privileged, and I have a voice in this community. It is why I take on the roles that I have, because I'm willing to ask those questions, to challenge the norm, and really just try to do my best to make at least one person's life better every single day. Like, that's all I strive for. And it can just be an act of kindness, and it also could be giving somebody access to their life-saving medication. All of it counts.
Wow.
That's beautiful.
So not only did you give a great answer, but you didn't even hesitate. That was amazing.
She was on it. I love that, Marka. That was absolutely fantastic. And the one thing I think is really interesting is I was listening to something the other day, and it was talking about the way various societies view individuals that are influential and or important. And one Western society is a push of how much you have shows how important you are. But something that ends up happening oftentimes in tribal and or indigenous cultures is how much you give is how important you are, in general. Yeah. I think there's something to that level of humility that you kind of ask for, not only of larger corporations, but as us, as healthcare providers, and being able to do some of those steps, take some of those steps toward giving, toward providing more, when it comes to our patients overall, so that we can get to some of those common goals, which are important. What things, Maka, for a last question, would you encourage any of our listeners, the ASCP groups, to maybe give a little bit of their time to, or do a little bit more of, that you've experienced over the years, do you think would be beneficial for them and especially their communities?
Yeah. Well, I'm going to say first and foremost, I think they need to give into themselves. Like, I think that as healthcare providers, the burnout is extremely high. And we need to be the first to recognize if we need help. I mean, depression numbers, suicide numbers are extremely high in healthcare professionals, in pharmacists right now. So if we need help, you cannot be afraid to raise your hand and ask for that help. You cannot provide help for other people if you are not taking care of yourself. So that's, I think, first and foremost. But beyond that, I think any little contribution you do in terms of just helping somebody unblock a barrier in their life. Ask them, how their day is doing, or if you see somebody who fell down, go and pick them up. Go ask them if they need help. Open a door, right? You don't know where people are mentally or physically these days. And even those small actions can mean a lot to a person, to be seen, to be able to voice something that they might not have been comfortable to do. And those little actions lead up to big actions. And that's when big change happens.
Love that. I love that.
It. Yeah, that's great.
Yeah, Maka, I think the only things I have for you there are, you know how much I love rural, so I'll be getting a hold of you really soon on how we can work together about some of the Native American situations and some of the critical access communities I've worked in the past. I'll try to open as many doors for you, my friend, as I possibly can. And
Thank you.
Jaron, I'll always open a door for you, buddy. Absolutely.
No, stop it.
I know. Any last questions or statements, Maka or Jaron, before we wrap up this episode?
No, thank you so much for having this discussion tonight.
Yeah, I really enjoyed it. Thanks for joining us. This was great.
Well, awesome. Well, thank you everybody for listening in and tuning in to The New Frontier. You can find us on YouTube, and I'm sure a bunch of other locations that the team at ASCP will fill in for us. And hopefully we'll get to see some of you. I know it's coming up really soon, but in October, we've got ASCP Annual coming up. So hopefully we'll get to see some of you in person. I know Jaron and I will be there in person. I'll get to hug this guy finally and see him live. So I hope to see many of you there and get to enjoy the same things. I'll try not, if you're non-hugger, you can let me know.
No, I'm a hugger. Yeah.
Well, good. I love it. Okay. Fantastic.
It'll be a warm embrace.
Well,
Go
fantastic.
Cougs.
Well, thank you, Maka, again for your time, and have a wonderful night, everybody.